Good morning, everyone, and thank you for joining us for this AGA webinar on building a non-procedural GI geriatric service line. I'm Dr. Larry Kosinski, the chairman of the AGA Practice Management and Economics Committee. I'm in private practice in suburban Chicago, and I'm one of the managing partners of the Illinois Gastroenterology Group. This webinar is the second webinar in a series of 3, which we hope will help you as you consider ways to expand your practice services to boost revenue from non-procedural business lines. The AGA Practice Management and Economics Committee has been focusing on non-procedural business lines since 2011 and has identified several potential business lines that represent high-frequency, high-risk services. We've also identified multiple experts in the field to provide their insight and advice. Today I am joined by Dr. Karen Hall, who will provide a summary of the GI geriatric service that has been developed at her institution, University of Michigan Healthcare System. She will discuss how, at her institution, their program allows gastroenterologists to provide non-procedural care for geriatric patients while triaging them for endoscopy and other procedures. The first webinar in this series, which is available on gastro.org, focused on nutrition. The next webinar in the series will be presented in October and will focus on women's health. We're having some technical difficulties this morning, but please note that all your questions will be answered at the end of the webinar. To ask a question, type your question into the question pane. So let's start with my first slide, which states colonoscopy is a mature service. When I took over the Practice Management and Economics Committee back in 2011, it became clear, as it is to everybody today, that colonoscopy is a mature service. And as a mature service, just like any other mature service or product line in business, we are seeing economic pressures on us. Reimbursements falling, costs rising, and our margins are under compression. We're also vulnerable to new technologies that could replace what we're doing because of this financial structure. Colonoscopy is responsible for over 50% of our revenue. For some of us, it's 60 or more. So it's very, very important now to start seeking out other types of non-colonoscopic service lines. Next slide, the slide that says cost drivers. Most gastroenterologists, if they're asked to draw a diagram about what percentage of their services come from each of their service lines, they probably would draw something similar to this slide, with a very large portion being driven by colorectal cancer screening and surveillance, and much smaller ones on hepatitis, GERD, and inflammatory bowel disease. Next slide. On this slide you see from my practice, IGG, we are 38 physicians. This is our top 10 ICD-9s by reimbursement from a couple of years ago. And as you can see, over 50% of the costs that we impose on the healthcare system emanate from the treatment of colorectal cancer screening and surveillance. Next slide. This is a payer's view of what the various relative components of the GI service line should look like. Colorectal cancer is smaller than in our view because the payer is seeing a much higher proportion of expenses that really are not reflected in what we are making. So this is what's happening out there without us knowing it. Next slide. On the Crohn's disease expenses, this is slide number 6, if you look at the proportions, about 1/3 of the expenses for Crohn's disease are for inpatient services. Another 1/3 for outpatient, where you find your biologics, and a final 1/3 for professional services. Next slide. Over $250 million in annual expenses are incurred by our major payer in Illinois, and over 40% of all those expenses are paid for hospital services, likely related to complications. This is the fastest growth area of expense. GIs are only receiving 3.5 cents on the dollar of what our major payer is paying for these services. But we're supposed to be managing the illness and its complications. So there is an opportunity to improve care here at the provider level, and a potential for a shared savings program exists. It was these concepts that led us to start looking into the multiple other potential service lines. Next slide. Jay Cummerly presented earlier this summer on nutrition. And that seminar is available on gastro.org if you missed it and would like to see it. Today, Karen Hall is going to present on geriatric GI, and the next one we have scheduled on October 9th is Kim Persley from Texas is going to speak on women's GI issues. Next slide. So what does this all mean? It means GI reimbursement for our procedures is under threat. It means that we need to focus on what the changing market needs, and we need to expand and diversify our service offerings so we can bring in additional revenue from other entities. Change is an opportunity here, and we should all be trying to grasp it. At this point, I am going to turn it over to Dr. Hall. Karen, you have the platform, and hopefully our technological glitches today will end.
Great. Thanks very much, Larry. I'm really happy to be talking today about this because this is a subject that's near and dear to my heart. I've been working in the AGA for a long time trying to integrate geriatrics into GI care. And what I wanted to do today was talk a little bit about what's driving that effort, and also how we do it at the University of Michigan and how people might be able to use the model that we have and extend it into their practice. So my first slide is just a title slide showing building a non-procedural geriatric service line. The next slide, titled Why Incorporate a Non-Procedural Business Line into Your Practice, kind of goes over the big picture here. So obviously there are procedural RVUs for GI, but there are also non-procedure RVUs, so visits and other types of billing. Another issue that I'm going to talk about a little bit is marketing, and I think for this group of people, the geriatric age, this is actually a very important area. So when you want to incorporate this into your business, you need to think about how are you going to get referrals and how do you persuade people to come. The collateral benefits that we see is we think we have improved outcomes. We've definitely coordinated care better between primary care and GI. Gastroenterologists are recognizing the impact that the functional impairments that these patients have on their ability to deliver care, and they're able to triage procedures, I think, more appropriately for this group. And then another collateral, which is important to us as an academic institution, is that we can robustly document geriatric GI training for residents and fellows that comes through, because we have explicit clinics and explicit opportunities with known numbers of patients. So the next slide, which is an overview, is why I think you should beef up your care to include geriatric GI and what is going to constitute success in doing that. So first of all, we've got this aging tsunami coming at us. The first baby boomers are turning 65 now. Most of them are going to see a gastroenterologist at some point for something, a lot of them early on for triaging and doing screening. And then even in later age groups, they do see and have gastroenterologist-related problems. The procedures are going up. You know, the percentage of procedures in this group is a larger and larger percentage of all the procedures, and even the non-procedural consults are increasing. So this is where the action is, or it's going to be. There is a chapter in the curriculum called Geriatric GI. It has defined objectives, but in talking to training programs, most training programs don't really have defined curricula yet in geriatric GI, so this is an opportunity for you to work on that. And then we know that if we identify your group as a geriatric-friendly group, it actually does increase referrals. And if you are looking at joining an ACO, or you're already in one, or you're imminently going to be in one, it does align pretty well with their goals. Next slide. So who needs the geriatric GI approach? So I've just listed some examples of the kinds of patients that come into our clinic. We have weight loss. Besides cancer and other things that would concern us, recognizing depression is something that our gastroenterologists feel pretty comfortable doing now. Medication errors causing GI symptoms. We've had demented people who didn't take their meds properly, so recognizing that. The risk-benefit ratio of colon cancer screening and trying to figure out how many years of life someone has left. Dysmotility syndromes are very common in this group, so getting a good way of handling that in your clinic is helpful for their quality of life. And then finally, there's a group of younger old patients who we know are probably going to increase the number of hepatitis C patients who are being followed. These people are just entering the geriatric age range now, and I suspect they're going to age in place with hep C and also with NASH and fibrotic liver disease. So that's the kind of spectrum of patients that you might see. The next slide is an example case of someone who came in and was jointly handled by gastroenterology and primary care. This woman who was 78 came in with weight loss. She had actually been seen by a couple of other groups, had endoscopy. There wasn't really any explanation for her weight loss. We got screening by social work staff in our clinic, which is something we can offer to the GI people there. It showed that she was not really functioning very well. She couldn't cook, she couldn't get food, and her depression screen was positive, and so was her dementia screen. And so the gastroenterologist was able to incorporate all of this testing, which was actually done by our ancillary staff, made some recommendations, and the family was very happy because it turned out depression was probably the cause. And the gastroenterologist saw the patient twice, so a consult and a return visit, and used our geriatric staff to help guide the care. The next slide shows another case of a guy who was a somewhat older, 87-year-old man who was regurgitating food and coughing. These patients are actually usually very difficult to get into the clinic because the providers who look after them or their children who are looking after them can't take time off work. And this is actually an issue I'll address a little bit further in the talk, because if you can make the model a sort of same-day service or bundled visit, they will really appreciate this. So the patient appeared to be Parkinsonian, so we have neurologists in our clinic. We have geropsychiatrists in our geriatric clinic. Neurologist was able to see the patient, said, get a GI consult. Gastroenterologist was in the clinic, so saw the patient the same day, ended up getting some testing done, and although it was suspicious that the patient had been not transferring food properly because of Parkinson's, actually the cause was a Schatzki's ring with some narrowing, and food was impacting there, and so there was a dilation done. And the family was very happy because instead of the 8 or 9 days it would have taken off work to fix this and figure it out, they only had to take off 3.5 days. And the GI provider was very happy because they got the patient diagnosed and treated pretty quickly. New paragraph. Next slide. So geriatric clinic at the University of Michigan. So here's what we do at the U of M. We have 3 half days where there are GI providers. There's 2 half days, one on Monday and one Thursday afternoon, and there's 2 providers on each of those days. And each provider is seeing about 8 patients for a total of 16 or so per half day. We also have added hepatology because of the starting to see an increase in the number of people who are diagnosed with hepatitis C. In Ann Arbor, we've got a fairly big immigrant population who've moved to be with their kids who work at the U of M, and some of them, a lot of them are turning out to be Hep B positive. So we've had some interest in getting a dedicated hepatology clinic. We see about 30 to 40 patients per week in these GI clinics. The things that the geriatric clinic are able to offer the gastroenterologist is that there's a social worker in clinic every day, and there are these other specialties in the clinics most days, so you can get an immediate consult with either a primary care geriatric attending or one of these specialists. Next slide. So physical resources. We have our own clinic building, the geriatric clinic. There's an adjacent building which is a medical procedure unit, and it's run by the GI division. And we also have dedicated radiology and lab facilities on site. So that's very important for us because quite often a plain x-ray of the abdomen or a quick stat labs can help tell us whether this patient's constipated, whether they have some acute issue that needs to be sent to the ED for. And there's also a shuttle bus to the main hospital so we can get the patient into the main hospital quickly if we need to. The geriatric medicine clinic staff are incredibly useful. So all of the medical assistants, the RNs, are all very geriatrics friendly. They're used to dealing with older patients. The RNs can also do some basic procedures like wound care or enemas. We do not do any sigmoidoscopy or procedures like that in the geriatric clinic itself, but there is the adjacent MPU. Next slide. So thinking about ACO care, it's a capitated pot, and they're going to be divvying it up between the physicians in the pot. We've found that this one-stop shopping model where we have GI and primary care in the same location is a very attractive thing for ACOs. As I said, the patients and families really prefer to see all the providers they can and do all the visits they can in one visit, and it really is a lot less time off that the caregivers or children of these patients have to take off work. The opportunity for curbside discussions has been great. We have improved access to other staff, dietitians and things that we can use to help us. And then we have found that this was also very attractive to the people who were referring patients to us for GI consultations. So the internal medicine group at the U of M and family practice have been increasing the number of referrals. And then we also think that it provides better coordination of follow-up with those referrers. And then if you're the provider, you can get involved earlier than the scope. You know, one of the issues we have, I guess, is patients being referred for endoscopy and they're kind of older and you're not sure that they're going to do well. We think that this has helped our GI providers in the clinic see the patients in a quick, timely manner and screen them before they end up getting them as open access patients. And then if you have an MPU on site right next to you, we found that that was a really useful thing. Next slide. So what kind of patients do we see? Well, so we're seeing about 1,500 patients a year in these 3 clinics. The average age is a little bit younger than the average age of the primary care patients. It's about 74, whereas primary care in the same clinic is about 81 years of age. A lot of them end up needing endoscopy. Actually, I was surprised by that, about 75%. 90% have at least 2 visits, so the initial consult and a follow-up, which generates about 3,000 to 3,400 non-procedural RVUs. And then we now have developed a really strong referral base. So we've got the geriatric faculty referring patients, other specialists, internal medicine at the U. The U of M ED knows about the geriatric GI clinic, and they've been referring, and also U of M family practice. And that's just within the U of M. So next slide. Who pays our costs? Well, so the costs are covered for the space and the staff by the ambulatory care division, and the medical procedure unit and their staff are paid for by the GI division, and then the faculty are paid by these 2 groups, but also there's a few that have some career development funds. And then the money that pays for this mostly is for Medicare, obviously. The patients are Medicare age. So they either have Medicare or they have Medicare plus a Medicare Advantage plan of some kind. We have got patients, however, who are Medicaid, and then there's a group that aren't eligible for Medicaid because they're recent immigrants, and they have this low-cost, low-service plan called the Washtenaw County Health Plan, which it's sort of limited in how much it does cover, but it does cover endoscopy and other things like that. And then we've been able to get some startup costs covered by grants for pilot care delivery, including the ACO project we had here. Carolyn Blaum, who left the geriatric division to go out east, actually got a large CMS grant to look at readmissions, and we were using some of that money. And then there's some ongoing clinical research projects looking at motility disorders in older patients, which provides some ongoing funds. So mostly Medicare. Next slide. So how does this practice market the service line? What do we do? Well, we're actually fairly developed now in our marketing. We did a lot of local marketing within the U of M using our website. It lists geriatric GI as a service line in geriatrics. We highlighted the fact there was multidisciplinary care. And then regionally, we published in some regional publications that would get to older patients, so Michigan Health. We contacted various primary care people and actually went and talked to them and explained what the clinic was about. Another important group is actually word of mouth. These patients talk to each other and they recommend each other. And then what I've found is useful is to present at meetings, and not just meetings, academic meetings, but actually going and doing outreach meetings at assisted living facilities and places where people work, or at senior centers where they're gathering. And that has been very, very good at bringing patients in. Next slide. So the recommendations that I would make is that if you're thinking of adding this kind of thing to your service line, you should probably do a pre-assessment of how many people there are in your area, your catchment area, that are in this age range, and are you actually seeing them at all? So if you find that there's a large group of geriatric age patients around you, but you're not getting them referred in, then there's a missing opportunity there. If you are already pulling them in, then you have to look further afield and ask yourself, is this going to result in more referrals, or are we already getting as many people as we can? I would definitely recommend contacting patient advocate groups. So we have one at the University of Michigan that's quite active, a geriatric advocate group, and they are actually very useful at pulling in people's opinions in that age range and also disseminating the word that you're a geriatric GI clinic. Asking them, would they come? What if it was in the same space as primary care, if you can find a group that you can collaborate with. And as I said, go where they are in assisted living and senior centers and give talks. Next slide. Collaboration with primary care, I think, is pretty important in this group because that's where the referrals are coming from. If you can find an existing group in your area that has patients in this age range, a large cohort of them, then that's the group to see if you can align with. It may be that you're about to join an ACO, so you should talk to the people who are setting up the ACO about this. They may be able to help you get started and even actually pay for some of the startup costs. Ask yourself, do you have support for older patients? So besides the test procedures, pharmacy, believe it or not, valet parking. Sounds ridiculous, but it actually is fantastic for the patients. If they're coming on their own or with their aged spouse, then it's great. If they're with their kids, the kids may need to accompany them in, and the valet parking really is a great draw. Next slide. Is your facility elder-friendly? Well, it helps if you don't have stairs. I mean, obviously an elevator is okay, but the more multiple levels you have, the harder it is to negotiate. Can you get wheelchairs in and out of the facility? Are the corridors wide enough? We actually had a situation where they put a carpet into our waiting room, and the carpet was very nice and elegant, but it was actually a very sculptured carpet with a lot of ups and downs, and it turned out to be a huge tripping hazard, and no one had actually asked geriatrics whether this would be a good idea. So we had to take the carpet out. So it's probably good to get the opinion of some people who are in the geriatric field as to whether your facility is elder-friendly. Again, is there another group that can pay those costs to renovate your facility? Is your staff elder-friendly? So some people really like working with older patients, others don't. If you're going to add this service line, you probably want to talk to your staff about whether they're on board with this. And then obviously Medicare needs to be able to pay your costs. And so you need to look at the bottom line and figure out whether the reimbursement from that is going to pay your costs, and then look at whether the increased referrals will make a difference for you. I don't know whether there are going to be any new codes coming out for GI care. There actually have been some new codes coming out in Medicare for transitional care coordination, which was to address the high-risk 2-week period after discharge from hospital where most people end up bouncing back, about 70%. If it turns out that there's some areas in geriatric GI where a new code would be a nice idea, then going down the line, we can feed that back to the people who talk to CMS and see what happens. So last slide is lessons learned. So what did we learn? Well, we certainly learned that you leverage what you've got. I mean, before you rush out and build a new building or start a whole bunch of new clinics, you really want to find out, well, can you insert yourself into someone else's clinic, into a primary care clinic? Do they already have staff and facilities that you can use so you don't have to hire a social worker? And then is there some collaboration that's already going on or being started in your institution, and would this align with it? And I wouldn't overlook the training issue of this. Training facilities sometimes have money if you can document that their trainees are going to get experience in geriatric care, and this includes non-physicians such as nurses, social work, pharmacy. So check and see whether there are groups there that are interested in having people go through a clinic like this. Don't underestimate the importance of good staff and geriatric-friendly staff, and then sell your product. Go where the patients are. Go and talk to them, because that probably will get you more action than just about anything else. And then my final slide shows a picture of our facility. In the middle is a sort of strange square thing, which is actually an awning, so people can drive up out of the rain. And then right behind it is the geriatric center. And if you need more information about that, there's a website listed just below that. So with that, I'd like to stop and turn it back over to Larry.
Well, thank you so much, Karen. That was fantastic. I have a question. Well, first off, we have a few minutes to take some questions. I don't know if staff have, how many of staff have already taken in, but as a reminder, if you have a question, please type it in the question pane, and then it'll be answered in turn. If we can't get to all of the questions, I'm sure we will, though. We'll post a Q&A online. But Karen, I want to start it out by asking a question. You're right. This silver tsunami is enormous. We're adding 10,000 Medicare beneficiaries every day, and we're going to do that for the next 10 years. And everybody talks about that, but you refer to the fact that, okay, 10 years from now we have this 75-plus age group patient that is going to have to be taken care of. So that tsunami is just going to move its way further into geriatric. Can you, just for my own edification, what are like the top 3 issues you see on a regular basis?
So motility disorders. So unfortunately, this age group seem to be high risk for constipation, unrecognized constipation, fecal incontinence from constipation, and diarrhea as a smaller cohort. So these are things also that impact their quality of life. Dysphagia is a big one. So it's unusual at all to see people who are dysphagic. You won't see 65 to 75-year-olds being dysphagic, but if you start to see that aging cohort where they're now 85 to 90, about 10% of them have almost aspiration, unrecognized aspiration. So if you take about 100 normal 90-year-olds off the street and you did a swallow study, about 10% would have some aspiration. So as we go forward and the age gets older, we start seeing, these sort of motility disorders that impact them all the time. And as geriatricians, we're trying to balance that off against quality of life, and also, how is this going to be treatable? Is it treatable, and how do you manage it? And what does this mean for the patient? Should they be aggressively treated or not? I think one of the issues we're facing now, obviously, as this cohort goes through, is at some point screening becomes either unnecessary or not indicated. And there's been a lot of argument, as you know, about at what point do you stop colon cancer screening, for instance? And should there be an age cutoff, or should it be age and function cutoff? And are we prepared to really know how to assess someone's function? So, you know, the ACP came out and said 75 and older, no. There was a huge backlash from that because there's a lot of 75-year-olds out there who are pretty high functioning, and they said, are you kidding? You're going to cut us off from all screening? But there comes a point where the length of life left, or the length of life and quality of life, collapses below 5 years, and then it probably is more dangerous for the person to get the procedure than to not. And so deciding where that occurs has been a real issue, and you'll see various publications talking about age 80, 85, 83. So every gastroenterologist that's seeing this age group is going to be dealing with that. So they need to feel comfortable themselves being able to say, you know, yes, you should have it, no, you shouldn't. The other thing I know is going to happen is the baby boom cohort are a fairly entitled group of people. So telling them that they shouldn't have this and that is going to be a bit difficult.
Yes, absolutely. Those motility disorders are really critical. You know, you and I probably are seeing a similar age population. I've been in practice for 30 years, so a lot of these patients have aged along with me. And what a lot of people don't realize is, you know, body mass, muscle mass declines with age. These elderly decrease what they're taking in gradually over the years, and their colons have a lot less exposed to them, which results in a lot of problems with bowel dysfunction. And I see that all the time. That's important to think about. Let me ask staff: do we have questions that you'd like to handle?
Yes, we do. Thanks so much, Larry, and thanks again, Karen, for that excellent presentation. The first question that came in is, Karen, can you speak a little bit more about the process of actually deciding to develop the geriatric service line? Who in your practice or in the larger University of Michigan health system was involved in the decision-making process to actually incorporate a geriatric business line?
Okay, good question. So at the University of Michigan, we have a somewhat unusual geriatric clinic in that there are a lot of specialists practicing there. And that's directly as a result of the chair, who was the chair for many years, Jeff Halter, who just recently stepped down and passed the baton. And he's an endocrinologist, and he felt that it was very important that we be able to offer more than just primary care in the one space, because he had heard from families and patients how frustrating it was for them to try to negotiate the system and get from one provider to another and one specialist to another, and the specialists wouldn't talk to each other. So they developed this model of bringing in specialists. I arrived and joined the faculty, but I don't do endoscopy. So what we did is we looked for someone in the GI division who was both interested in older patients and who was doing endoscopy, and Rick Sod was there. And so the next thing that gave the impetus to it was that we had a couple of other champions in the GI division who were interested in this particular area. They saw it as a, a career opportunity, and they were interested in those patients. So we needed that. Another thing that made it possible was that we moved from a building which was quite close to the hospital and quite convenient for our patients to a building that was further out but had a lot more space. And it turned out we were able to make it just as good for the patients, but it allowed us to expand the number of exam rooms and then bring in more people. If we hadn't done that, I don't think we could have added the GI to this, because it just takes more space. The internal medicine division was very supportive of this, so they were able to get us the building, pay for some of the renovation costs. We had to make a decision about procedures, would they be done in the clinic or not, but luckily the space we were looking at also had an MPU, and that was another big factor. So it was an alignment of some opportunities for growth, also an alignment of the philosophy of the then chair of geriatrics.
Thank you. Next question that came in, have you been able to calculate the increase in market share, and if so, what increase in market share did you incur?
So we haven't done a formal calculation. I think that looking at the types of patients that are coming in, there's probably about 25% who are coming from outside the U of M catchment area. So from Ohio, Monroe, which is about 30 miles south of Ann Arbor, Kalamazoo, Brighton, and 10 or 12 miles north. So the U of M has some satellite facilities, but what I've been struck by is that patients who come in have been self-referring in, about 20 to 25% have been self-referring in from other medical systems. So we seem to be getting a catchment area now for the clinic that's about 50 miles further out than the U of M catchment. I think that's probably due to things like the website. So patients go on and they search all the time now on the web, and I think they're running into the U of M website, and when they do, and they search for geriatrics and GI, they find a defined group, our group, whereas in other centers they might not. So I think that's probably what we've done. Now, in terms of how much revenue that's generated, I really can't say for sure what that number would be, but obviously that's probably resulted in procedures and visits that wouldn't have happened otherwise. The bulk of our referrals are still coming from the University of Michigan, but more people are sending patients to the Geriatric GI clinic than to some of the other GI clinics. So I guess what you have to do is look and say, well, you know, you don't want to cannibalize your own patients, et cetera, but you know, would you lose those people, for instance, if you didn't have the Geriatric GI clinic? That's a harder thing to answer, but it's a possibility. You know, if another group said, oh, we can do this too, would those patients go elsewhere?
Thank you. Next question. What kind of coordination do you have with the inpatient facilities in the University of Michigan healthcare system and, as you mentioned, other medical systems in your regional area, so that if one of your geriatric patients does show up, let's say in the ER, for example, for a GI issue, that your clinic is aware of that?
Right. So we actually have a care manager, so it's one of our nurses, is constantly monitoring how many patients are coming in the ED and which patients are being admitted and who's being discharged. And when she gets that list, she not only looks at it from the point of view of primary care to try to coordinate those transitional care visits, but she also notifies the specialists involved, particularly if it looks like they're going to end up having to have a follow-up visit in that specialty clinic. So the GI and neurology and geropsych and all these other groups that are in the geriatrics clinic get the benefit of the care manager telling them. So we try to coordinate that. I think coordinating care is a huge problem, but we found that that's probably the best way that we've got right now, because that person's within the clinic space, so she can quickly arrange things like that. In terms of the coordination of other providers with our clinic, we have at the University of Michigan an automatic notification process. So again, it's mostly directed though at PCPs, and so that's sort of a blank spot, which I'm sure we're not unique in, that we don't probably let the specialists know in a timely way as well as we might. And going forward, you know, can we do something about that? We have a new EMR that we just put in last year for our outpatient group called MyChart. It's an Epic platform, and hopefully once it goes inpatient next year, we can actually use that to notify specialists.
Thanks, Karen. So I think that's all the questions that we've received from our audience. So Larry, I will turn it back to you.
Thank you, Laura. Well, thank you, everybody. Thank you so much for joining us today on this webinar, Building a Non-Procedural GI Geriatric Service Line. The recording of this session will be available on the AGA website in a few weeks. Additionally, the entire online publication on non-procedural service lines is available on our website, gastro.org/practice/building your non-procedure business line. Finally, continue to read AGA e-Digest for more information about the next webinar on women's health and to register. Thank you, and everybody have a great day.
Great. Thanks, Larry.